Hi everyone, I am Dr. Alexander Balan and today we will discuss a subject which is not to skip and of clinical importance. It's called meningitis. What are the objectives of our lecture is to review the causes of meningitis, describe the presentation of a patient, symptoms and signs, summarize the treatment and prevention options, describe modalities to improve care coordination among interprofessional team members in order to improve outcome for patients affected by meningitis. We'll start with some statistics, and as you see, despite breakthroughs in diagnosis, treatment and vaccination in the year of 2015 were 8.7 million reported cases of meningitis worldwide, with subsequent deaths with a number of 379,000. It's a lot. It is a life-threatening disorder that is most often caused by bacteria or viruses. And before the appearance of the era of antibiotics, the condition was universally fatal for all cases. The condition still carries a mortality rate of close to 25%, despite of appearance of different types of or groups of antibiotics. Meningitis, by definition, is defined as inflammation of meninges, the dura mater, arachnoid mater, and pia mater that lines the vertebral canal and skull, enclosing the brain and spinal cord, of course. It's infection of all the meninges. Encephalitis, by other words, is the inflammation of the brain and not the particular part of meninges. It can be by infectious and non-infectious processes, and one of the example like autoimmune disease, cancer, paraneoplastic syndromes, or drug reactions as the non-infectious causes. Etiologic agents like bacteria, viruses, fungi, and less commonly parasites, but also could be. What are risk factors that provoke appearance of meningitis? Like chronic medical disorders, it's not a direct cause of meningitis, but it can contribute to appearance of meningitis, like renal failure, diabetes mellitus, adrenal insufficiency, cystic fibrosis. Extremes of age like too young or neonates and elderly patients, and under-vaccinated or unvaccinated patients. Immunosuppressed states like transplant recipients, recent transplant recipients, congenital immunodeficiencies, and acquired immunodeficiency syndrome. Living in a crowded conditions, exposures like traveling to some endemic area like southwestern US areas for cocci and northeastern US for Lyme disease in a Connecticut state. Vectors like mosquitoes and ticks. Alcohol use, presence of ventriculoperitoneal shunt, bacterial endocarditis, malignancy, dural defects, and IV drug use, sickle cell anemia, and splenectomy for Neisseria meningitis, which spleen is a organ of immune organs that destroy lymphocytes and other blood cells, and of course destroy bacteria as well, encapsulated especially. Some epidemiology, like in US, the annual incidence of bacterial meningitis is 1.38 per 100,000 with fatality rate of 14.5. So these days we are with a high fatality rate of meningitis. The highest incidence worldwide is in an area of sub-Saharan Africa, and it's dubbed the meningitis belt, from stretching from Ethiopia to Senegal. And most common bacterial causes of meningitis in US. Most common cause of meningitis in the US are bacterial, and incidence in 2010 year is the following, like Streptococcus pneumonia 0.3 per 100,000 of population ratio, Group B Streptococcus, Natrium meningitis 0.123, Haemophilus influenza less, Listeria monocytogenes, Staphylococcus aureus with recent surgery and especially neurosurgery, central lines which passing more than 5 to 7 days and are not carried well, and trauma, especially traumatic brain injury. Mycobacterium tuberculosis should be considered in immunocompromised hosts. Borrelia burgdorferi with travel to Lyme endemic areas like New York or Connecticut, Treponema pallidum in HIV or acquired immunodeficiency syndrome patient, Escherichia coli in the neonatal period. And most common viral agents are non-polio, like Coxsackie B viruses, ecoviruses, and other viruses also could provoke appearance of meningitis, like mumps, parechovirus, herpes virus, including Epstein-Barr, herpes simplex virus, and varicella zoster virus, measles, arboviruses. Fungal meningitis is associated with an immunocompromised host, as we talked previously with HIV/AIDS or chronic corticosteroid therapy appliances. Cancer. In cancer, we have two extremes, like immunodeficiency and appliance of chemotherapy or radiotherapy, which is also immunodepressive effect on immune system. Fungi causing meningitis, including Cryptococcus neoformans, Coccidioides immitis, Aspergillus, and Candida. Mucormycosis, more common in patients with diabetes mellitus and transplant recipients. Direct extension of sinus infection in patients with diabetes mellitus. And for this reason, as you see, we have to know in our minds that immunocompromised patients are of high risk to have meningitis. Pathophysiology, so we have two routes of inoculation, like hematogenous seeding and direct continuous spread. In hematogenous seeding, bacteria colonize the nasopharynx and enters the bloodstream after mucosal invasion, and upon making their way to the subarachnoid space, bacteria cross the blood-brain barrier and causing a direct inflammation and immune-mediated reaction. Direct contiguous spread is like organisms can enter the cerebrospinal fluid via neighboring anatomic structures like otitis media, sinusitis, or foreign bodies, or objectives like medical devices and penetrating trauma with different objects, or during operative procedures. Viruses, very important, can penetrate the central nervous system via retrograde transmission along neuronal pathway or by hematogenous seeding, especially herpes zoster, which is going retrogradely and affect patients. Symptoms typically include fever, neck pain, stiffness, and photophobia, and non-specific symptoms also can be added to the patient with meningitis, like headache, dizziness, confusion, delirium, irritability, nausea, and or vomiting. And also, to add for diagnosis, we can encounter signs of increased intracranial pressure, like altered mental status, neurologic deficits, any type, and seizure, which portend a poor prognosis of the patient. Evaluate the risk factors that increase clinical suspicion. History of exposures some sexual contact, animal contact, previous neurosurgical intervention, especially the last 2 weeks, recent travel to any areas endemic or pandemic, and the season. Of course, summer is a good time for fungi. In adults, the physical exam is centered on identifying focal neurologic deficits. And signs like Brudzinski and Körning signs, which are signs of meningeal irritation, and particularly in meningococcal meningitis. We have characteristic skin lesions or petechia and purpura on the trunk and abdomen. Cranial nerve abnormalities can be seen in around 10 to 20% of patients. In neonates, can be with or without fever or hypothermia. Also, decreased oral intake, altered mental status, irritability, bulging of fontanelle. And you should take into account all of these symptoms which afford for establishing diagnosis of meningitis. Diagnosis is through the cerebrospinal fluid analysis and include analysis in the cerebrospinal fluid of white blood cell count, glucose, protein culture, and in some cases polymerase chain reaction or PCR. Cerebrospinal fluid is obtained, of course, via a lumbar puncture, and we will see also opening pressure that can be measured at the same time. Additional testing could be for virus, PCR for fungi, cerebrospinal fluid fungal culture, and India ink, especially for Cryptococcus, for mycobacterial acid-phase bacilli smear and culture, for syphilis VDRL, for Lyme disease antibodies, for Burgdorferi. However, when the diagnosis of bacterial meningitis is seriously considered and patient is severely ill, antibiotics should be initiated immediately before performing a lumbar puncture, and do not delay appliance of treatment with antibiotics, which is vital. Computed tomography of the head, of course, looking for brain herniation or edema, that's a goal and should be done before lumbar puncture. Signs and symptoms that can show us herniation of the brain. So Glasgow Coma Scale, less than 11 points, lethargy, altered mental status, new onset of seizures of different types, simple or complex or local or generalized, and focal neurologic deficit. If the clinical symptoms are consistent with impending herniation, regarding of the CT, avoid the lumbar puncture and start treatment, and take blood culture, electrolytes, serum glucose, and renal and liver function, and also testing for HIV. Glucose level should be maintained in a range, adequate range, and do not exceed like 9 millimoles per liter or 18 around 180 milligrams per deciliter equivalent. What is the treatment for meningitis? So antibiotics and supportive care, which are critical in all cases of bacterial meningitis. Of course, managing the airway, it means to give patient oxygen or to transfer to mechanical ventilation, give sufficient IV fluids while providing fever control, and patient is of losing fluids through any of the road, by vomiting, by transpiration, or anything else. The type of antibiotic is based on the presumed organism caused by infection, if we have culture, of course. And below we have current empiric therapy with antibiotics that you have to take in account, and this information is latest update on November 7, 2021, and you can find this information directly on NCBI article, which is the source I made these slides. So current empiric therapy For neonates up to 1 month old, we are giving ampicillin and cefotaxime. Or also we can give ceftazidime or cefepime, or gentamicin, and acyclovir. So it means we are giving ampicillin plus one of these three, and gentamicin and of course acyclovir in neonates up to 1 month old. For patient or for children more than 1 month old, we are giving ampicillin and ceftriaxone. For adults, we are giving traditional or empiric ceftriaxone and vancomycin intravenously. And for patient with immunocompromised status, we are giving ceftriaxone and vancomycin and ampicillin especially for listeria. Meningitis associated with foreign body, post-procedure or penetrating trauma or traumatic brain injury, we are giving cefepime or ceftazidime or meropenem and vancomycin. Meningitis for patients with severe penicillin allergy, we are giving moxifloxacin and vancomycin. For fungal cryptococcal meningitis, we are giving amphotericin B and flucytosine by mouth. This one IV intravenously and this one by mouth. Do we know which antibiotic and which bacteria cover? Like ceftriaxone is a third generation cephalosporin. It covers gram-negative coverage and is very effective against Streptococcus pneumonia and Neisseria meningitis. So it covers the main bacteria that causes meningitis, and it is considered a drug for empiric treatment. Better central nervous system penetration than piperacillin tazobactam, which is typically used in gram-negative sepsis coverage. Vancomycin is a gram-positive coverage and MRSA or methicillin-resistant Staphylococcus aureus, also used for resistant pneumococcus. Ampicillin for listeria coverage, which is gram-positive bacilli. Cefepime, it's a fourth generation cephalosporin and have increased activity against Pseudomonas. Cefotaxime is a third generation cephalosporin and is equivalent to ceftriaxone and is safe in neonates. So if you don't have ceftriaxone, you are giving cefotaxime, which is also third generation, is equivalent as action of passing blood-brain barrier, and of course it is safe in neonates. How about steroid therapy? There is no sufficient evidence to support the widespread use of steroids in bacterial meningitis, but in any type of exams you will have answer like steroid applies for decreasing complications. And some studies report a reduction in mortality for Streptococcus pneumonia, but not for Haemophilus influenza or Neisseria meningitis. In children, were associated with a reduction of severe hearing impairment in cases of Haemophilus influenza meningitis. Some interventions to maintain cerebral perfusion, pressure, and of course to decrease intracranial pressure, like elevating the head of the bed to 30 degrees. Almost patients will be in intensive care, of course, as they are severely ill patients. So elevating the head of the bed to 30 degrees and inducing mild hyperventilation in the intubated patients, and by increasing respiratory rate or tidal volume. Osmotic diuretics such as 25% mannitol, which is osmotic diuretic, and or 3% solution, which is hypertonic. Also, we can administer furosemide, which is loop diuretic. We have to make differential diagnosis with many pathologies like stroke, subdural hematoma, subarachnoid hemorrhage, metastatic brain disease, and brain abscess that might coexist with meningitis. Prognosis: case fatality rate in 2010 in US was 14.3%, very high rate of fatalities that is finished with death, of course. Pathogen-specific mortality, we have number 1, Streptococcus pneumonia, Neisseria meningitis, and you see the respective numbers or of percentage. Group B strep and Haemophilus influenza and Listeria monocytogenes. Complications. A meta-analysis published in 2010 from a cohort of pediatric patients reported that the median risk of sequela post-discharge was 19.9%, around 20% of patients with sequela post-discharge. And the most common organism is isolated was Haemophilus influenza, followed by strep pneumonia. What are the most common sequela? Like hearing loss, behavioral changes, cognitive difficulties, motor deficit, seizure disorder, and visual impairment. You see the respective percentage. Other complications like cerebral edema caused by increased intracellular fluid in the brain, caused by, of course, permeability in the blood-brain barrier, cytotoxicity from cytokines released into the blood, immune cells, and bacteria. Also could have appearance hydrocephalus, cerebrovascular complications like ictus or ischemia, and focal neurologic deficits. That's all. Thank you very much for your attention. Hope this video is useful for you. If yes, you can subscribe or follow this channel in the future. Have a great time, guys.